about endoscopic ultrasound, concentrated rather on therapeutic aspects of this method of diagnostic and therapy. As probably you know, the beginning of US invented in 80 years. The beginning was rather for diagnostic idea of possibilities when it comes to the wall of the gastrointestinal tract, to check the wall of esophagus, gastric, duodenum and rectum, to recognize any thickness of abnormalities as tumor and organs surrounding the gastrointestinal tract. We are able to recognize which level, what kind, is it hyper or hypoechogenicity lesion. So this moment US was something more than gastroendoscopy, yes? And not only the wall, but also pancreatic and biliary and lymph nodes, left lobular, these organs which are surrounding gastrointestinal wall, and we are able to observe them and not only to watch, but also to take a specimen. And different kinds of needle let us to perform biopsy as a cytology or histology, depends on this, what's the aim of this procedure. For example, cytology in the situation when we suppose a neoplasm disease as carcinoma, and in the situation of GIST, what was about the last lecture, and neuroendocrine tumor, something more as histology. So thanks different new types of needles, we are able to use, thanks Procor needle or histology, a piece of tissue, not only the cytology. So it's one much bigger step for the future when it comes to the possibility of biopsy. Efficiency in US FNA is very high, but not 100%. Definitely all persons who are performing US FNA, we know that it's not 100%, and we have a problem in the situation when the cytology is recognized suggestion for neoplasm disease without sure recognize this kind of disease. In this situation, we need to repeat procedure. We need to be sure that the patient has benign, not malignant abnormality. So not 100%, but it depends of the center, but 90 is the very well result. Accuracy about 91%, as here is this multi-center study, above 2,700 patients. So very high accuracy and efficiency, and very high safety also. We must know that biopsy with a thin needle is rather safety procedure, and the risk for complication is lower than 1%. When we perform biopsy and puncture of the cystic lesion, it can be higher of the risk of inflammation. So always we should use then antibiotics prophylaxis in this situation. So US FNA is definitely the standard of the way of diagnosis, solid and cystic lesions in the pancreas. But US, which is developing in last year very intensively, doesn't let us only for biopsy, but also for different therapeutic procedures. This first, which was improved already in 90 years for US neurolysis of celiac trunk in the group of people with advanced pancreatic tumor, as treatment of the pain. Not only as alcohol, but also with steroids in the situation for chronic pancreatitis, if we don't have other possibilities for treatment. In this situation here, we have here Here what we see is the aorta with these two vessels, celiac trunk and mesenteric superior artery, and here the needle inside the area of celiac trunk. I'm sorry, but this doesn't want to move. And when it comes to the results of celiac trunk neurolysis, we must say that the efficiency of this procedure is about 70%. Not all patients after these procedures are relieved of any pain, but we are able to relieve in a part. So sometimes we need to repeat procedures after a few weeks because the focus and the place is not able to remove all nerves which are advanced in this disease. Not only celiac trunk neurolysis, but also different possibilities of connection luminal spaces. The first of them definitely is pancreatic fluid collection treatment, which is standard of care when it comes to the symptomatic pseudocyst and wall-off pancreatic necrosis. The next intra-abdominal abscess drainage, and this what I would like to say also is biliary drainage, when we don't have any access through the papilla by ERCP. The next, cholecystogastrostomy, a new method as alternative for percutaneous drainage with contraindication for surgery in this group of patients. And pancreatic gastrostomy, these procedures which were performed as a first today, and US-guided gastroenterostomy, and new possibilities of connection between different parts of gastrointestinal tract, and new possibilities of treatment of gastric varices and combined therapy, not only with cyanoacryl. In the group of people with pancreatic fluid collection, US treatment is definitely standard of art and treating method when it comes to management of this kind of abnormalities. Definitely it's safer with greater technical success than typical endoscopic without US. In this situation, we are able to treat the patient with pseudocysts, but we must remember that always symptomatic cysts. Very often, we must know that only 10% of patients with pseudocysts ultimately required intervention, and 20% patients with walled-off necrosis. So we must, in this kind of diseases, summarize our management into 3 steps. Delay, drain if necessary, and debride if we are pieces of necrosis inside the lumen of the cyst. So not each pseudocyst, not each ward-off pancreatic necrosis should be qualified for the treatment by US. Only in the situation when we have inflammation or if we have any symptoms. In the beginning, the first possibility what was used under US control was implantation of plastic stents. In this situation, these plastic stents were using for many years, and they are used for the future definitely also when it comes to pseudocysts, when we have clear and lumen of the cyst is clear without solid tissue, without debridement. This moment, plastic stents is enough without necessity of using metal. And the results of this situation and this kind of treatment is very efficient. As you know, here last year, a very good paper with very high level of patients, 142 patients treated for 7 years with very high efficiency above 90%. In the situation when we have something more inside the lumen of the cystic, we are able to move to use different stents, not only plastic but also metal stent. In this situation we have bigger lumen and bigger possibility of removing debris in this situation. So self-expandable metal stand, but this what we are able to perform nowadays is definitely using new metal stands, lumen opposing metal stands, which are connecting two different spaces. In this situation, cyst and the lumen of the stomach or duodenum. These prostheses are definitely shorter. The distance between two different spaces is very short, and the possibility for migration is definitely lower. Thanks this possibility of touch to the two different walls from the space of the cyst and the stomach. Hot axios lumen opposing metal stand as a one-step procedure is very important when it comes to the possibilities of therapeutic use. Thanks the time of procedure is much shorter, and we don't need to change any instruments through the biopsy channel. We are able to make this one step thanks this possibility of inputting the end of this equipment to the lumen of cyst, to the lumen of gallbladder, to the lumen of, for example, part of the colon or ileum filled with the water. And this moment we are able to compare these three different methods of drainage: pancreatic, metal stents, and lumen opposing metal stents. And when we compare them, we need to see the technique. And technical success is very high in all kinds of this procedure. A long-term success also. But when it's come about necrosectomy and possibilities of evacuation debris, definitely lumen opposing metal stents is the highest, 40%, when we compare with pancreatic. But adverse events in this situation will be higher when we will treat wall of pancreatic necrosis. Also bleeding, so we are thinking, and the papers, the conclusion rather is that it should be shorter time of treatment by lumps than with the plastic stents, which are treated by rather about 3 months, compared with lumps for 4, not longer than 6 weeks. Stent occlusion definitely lower in lumen opposite metal stents, and stent migration almost zero. So when we compare with other, for example, metal stent, it's very, very improved. So not only cystogastostomy, but also cholecystoduodenostomy, choledochoduodenostomy, we are able to perform with this kind of equipment. In this situation, we see the example of hepaticogastrostomy in the patient with cholestasis after lack of access to the papilla and without possibility of drainage by ERCP. So this moment we can perform or rendezvous therapy between intrahepatic ducts or extrahepatic ducts from duodenum to the papilla, or gastro or duodeno-hepaticostomy. It's definitely the alternative for percutaneous drainage, which this kind of the treatment is definitely technical efficiency is about above 90%, and complications are about 20%. But definitely, if it's positive and for the patient, the comfort of the life is definitely much better, way better than in the group of people treated by transcutaneous drainage. In this situation, when we have acute infection of gallbladder, so this moment, this new equipment with new instruments and with axios, mainly prostheses, we are able to perform also the drainage of gallbladder in acute cholecystitis in the patient who are not qualified for surgical treatment. And in literature for last year we observed many this kind of new centers performing this kind of possibilities of treatment by US. And not only by axios, but also with metal stents. But very important is puncturing gallbladder with the needle, later irrigating with saline, and inserting a white wire after white wire, dilatating puncture hole and placing metal stents. Authors propose that after a few weeks, if the gallbladder was not treated to the all, they implemented also plastic stents to the end of treatment. And can we look at the results? 100% technical success, 100% clinical and without adverse events. So very, very good results of this new paper last year performed. But when we are comparing with axios needle, and the results are similar, but the procedures is much more simple and only one step instead of here few elements which are necessary to perform. And here we have this example when we puncture the wall of the duodenum or gastric wall, and later we remove stylet, we improve guide wire, after guide wire 10 French cystotome, and after cystotome we implant metal stent. Here in this patient with advanced carcinoma of the head of pancreas, we implemented also the plastic pigtail to avoid an migration. Here we see the lumen of duodenum after metal stent of the stenosis of duodenum in pancreatic tumor carcinoma. This possibility of opening the gallbladder from the stomach and from duodenum allow us also to watch what's inside the gallbladder. Maybe in the future will be one of the methods of treatment, for example polyps or maybe stones. But nowadays we are talking about cholecystogastrostomy in the situation when we have contraindication for surgical treatment and the patient is with acute cholecystitis. So here is the result and radiological image of this prosthesis and lumen opposing metal stent, 78 patients, the paper from 2016, without serious complication, above 90% of technical and clinical efficiency. So comparable efficiency when it comes to the metallic stent and lumen opposing metal stent, less number of complications, well-being when we compare with external drainage. This procedure what was performed today in the morning, US-guided pancreatic drainage, we were talking about this procedure. It's one of the most difficult, much more difficult than biliary access for cholestasis. The reason is the tissue of the pancreas, a lot of calcinosis and abnormalities, that the tissue of the pancreas is very tough and it's not so easy even with the very good equipment to improve this into the pancreatic duct, but definitely smaller. With this what we use in our practice, it's definitely cystotome number 6 French, not 10. With the possibility of implementation plastic and or metal stent. This what is completely new and first time was recognized and first patients were treated this method is US-guided gastroenterostomy. First clinical study, 3 patients, all with clinical success. Next international multi-center comparative trial of US-guided gastroenterostomy with technical success 87, almost 100%. Is it alternative treatment for surgery and duodenal stents in the future? Definitely the most difficult point during this procedure is a good connection and visualization of this first part of ileum to make a good puncture of this part of gastrointestinal tract. So there are a few possibilities. Direct US gastroenterostomy, when we have, when the wall of the stomach is exactly at the level of this part of ileum, assisted when we put water inside the lumen of the first loop of ileum, and the best of them, the third one, US guided balloon occluded gastroileostomy bypass. So first papers 2015, 2016, about 50 patients, and very high technical success, 90, 100%, and none or mostly about 10% of complications. So it's here, the picture show the possibility of puncture with balloon, with the techniques with balloon, and the reintervention rate was much lower when we compare this kind of treatment with prosthesis of the duodenum in the situation of outlet gastric obstruction in malignant diseases. Technical success when we compare with surgery is similar, but in the situation when there are contraindications for this kind of treatment for surgery, we are able to perform by US, and here we have to punction, injection, putting the needle to the ileum, and next open the axios stent, and here we have the picture of opened axios stent and connection between stomach and ileum. Minimally invasive and avoid morbidity, which can happen during surgical procedures. The development of anastomosis stent with electrocautery, enhanced delivery system, this is what I was talking as an axios lumen apposite metal stent with one-step procedure. Definitely for this kind of procedure, this one step is the best one, because as you know, the stabilization of this equipment is not so easy when we need to remove and change different instruments during performing procedure. Direct puncture, initial needle, and later possibility of performing this procedure as alternative method for surgery and endoscopic stenting. But not only the gastroileum, we are able to perform also other connection between gastrointestinal tract. This is the patient after surgical treatment with enterostomy, after problems and complications of gynecological diseases. And the patient had enterostomy, and in this situation we input through the rectum US, and we input a big volume of the water into the end of the sigmoideum, and this way we connected the lumen of the rectum together with the lumen of the sigmoideum, and we input in this place axios stent with the biggest diameter. We input balloon inside this lumen of this axios to receive as big diameter of this prosthesis as possible. And here we see this in the radiological image, and we are observing opening the first part of prosthesis inside the sigmoideum, and here the next part in the rectum. This procedure we performed a few weeks ago. Now we are planning to remove this enteroscopy, and we hope that in the future the patient will be able to have the passage of the colon without gastroenterostomy. Here we are able to observe opening of the axios stand inside the rectum, and we see the lumen of enteroscope, which was putting the water into the sigmoideum. So the connection between two different parts of the colon after axios therapy. And as the last one, what I would like to talk about is the possibility of treatment when it comes to the portal hypertension. As we know, the standard of method of treatment of esophageal gastric esophageal varices is banding. But in the situation of the gastric varices, we use cyanoacryl as a glue, which helps us to close this, the biggest varices in the gastric lumen. But US let us not only to show these varices which are superficial, but also let us to show perforating veins and these vessels which are around the wall, deep varices as para and perigastric varices. So using US we are able to input cyanoacryl to the biggest diameter of the varix, and also for perforating veins, what is not possible for gastroscopy. The new method and possibility for treatment is implantation of coils, which are using in radiological interventional therapy. And in last years, there appeared few papers about not only monotherapy by glue injection, but also combined therapy, cyanoacryl together with coil injection. So metal coils are covered with synthetic fibers, which promote cloth aggregation and can provide a scaffold for glue adherence. So this moment we don't need to use so big volume of glue because we have a scaffold which helps us to give only a smaller volume of cyanoacryl. And maybe this method will be able to let us that therapy of gastric varices could be more safe, thanks lower risk for embolization, pulmonary embolization. So guided therapy connected cyanoacryl with coil gives us any chance for the future when it comes to the new kind of treatment. On this view, we have very, very dilated gastric superficial vessels together with perforating veins, and this is what we are able to say in Doppler. We are able to also to puncture. We choose the biggest diameter of the vessels in the gastric wall, and this moment we see the end of the needle, and we remove the stylet, and in this place we replace the coil. Here we are able to find on the top of the needle, we see the coil which is inside the lumen of the varix. And thanks this method we are able to have stop of the flow, the liquid and blood inside the varix. And we see that in the Doppler examination, this flow is not so intensive as before, and as a next step, we are able to put a glue in the same place, so we receive what we are able to observe, that we don't have any flow in this place after this combined treatment of gastric varices after implementation of coil and injection of glue. So probably this combination will be maybe the future, but it requires randomized multi-center definitely examinations. Polish study about 17 patients, about 50 implanted coils, follow-up every 3 months, and we compare single coil therapy together with concomitant therapy. What's with the future of US? This is what is planning probably for 2020. Definitely FNA as a basic when it comes to the diagnosis, to the neoplasm disease. For all of the years, definitely neurolysis of celiac trunk, drainage of the pancreatic fluid collection, bile duct drainage, but also gallbladder drainage, but with this new prosthesis, lumen apposite metal stent. Maybe the future, but the inquire, will it be the future? Vascular therapy, ablation of the tumor and cyst, implantation of and therapy in oncology, pancreatic duct drainage, and gastroimmunostomy. Thank you very much.
Спасибо большое, Анна, за очень интересную, очень подробную, детальную лекцию по интервенционному ультразвуку. Я думаю, что у кого-то возникли вопросы, действительно есть методики, которых очень редко и мало где выполняют и мало где слышали. Кому угодно задать вопрос, пожалуйста, поактивнее.
Thank you, Anna, so much for your lecture, and I have a couple of questions for you.
Thank you.
And first is, do you have an experience of radiofrequency ablation for biliary cancer using EUS guidance?
Unfortunately not yet. In Poland only there's the beginning of this kind of method. I know that Archidiacono in Italy, in Europe, he's interested in this kind of method that has very good results. We can use radiofrequency in 2 different kinds of procedure. First of them is the treatment of tumors, solid and cystic tissue, and cystic tumors inside the pancreas. But the other method of radiofrequency, when we have any problems with restenosis of biliary tract, so also radiofrequency is possible to perform the lumen of these biliary tracts in this situation. But definitely the future with this radiofrequency for the treatment, but not so advanced tumor and neoplasm disease of pancreas, only this without inflammation for vessels. Because in this different situation we are not able to use. So maybe, unfortunately, the pancreatic carcinoma is so advanced that we are not able to use almost this method of this reason of inflammation for the vessels.
Okay, thank you. And my second question regarding EUS hepatic gastrostomy, you talked in your lecture. And the question is how wide this technique is used in Poland, and how many hospitals are able to perform this technique, because it's really rare too.
Yes, but I must tell you that last 2 years, we see the development of this kind of method. I see that a lot of endoscopists who are performing ERCP, and which in these centers, when they have possibility to use EUS, even in the same procedure. If they have a problem with biliary access to the papilla, so this moment they are able to exchange procedure for EUS. The best when it comes to the access from duodenum, close to the papilla, so it's much more safe and easy, even for the endoscopists who are not so advanced when it comes of EUS. But there are few centers in Poland who perform. One of these, I worked in Szczecin, close to Baltic Sea in the northwest, in Warsaw, in Rzeszów also. So few, but I see that the chance for development of this kind of method is very high, and these centers are very glad of this possibility, yes. But I must tell you that sometimes, because the best doctors in ERCP, sometimes they are not so advanced in EUS. So I think that it's a good idea to connect, to create a new team with the one person who is advanced in EUS, second ERCP, and to make some great procedures all together.
Thank you so much. Вопросы из аудитории?
Ну что ж, вопросов нет. Да-да. Давайте мы, уважаемые коллеги, поблагодарим нашего эксперта, поблагодарим Анну, поприветствуем ее за ее работу операционно и за ее работу, за ее лекцию здесь. И по сложившейся традиции мы вручим Анне диплом эксперта фестиваля и, конечно, книжку о Москве. К нам вернулись из операционной наши эксперты.